I'm Sarah Farrant, so I'm an optometrist down in Somerset, and I've been dealing with dry eye in my practice for about 8-9 years, pretty much ever since I qualified. And today I really wanted to use the opportunity to give you a live demo. I've got my mum along with me today. She's got blepharitis. So I wanted to really show you exactly what I do in practice and how I do it, and literally do a dry eye routine as I would do it in my practice. So hopefully, as long as we can get the tech sorted, we'll be able to do that. So in terms of dry eye itself and what it really means for me and hopefully for all of you as well, is that it really is a growing problem. Not only are we becoming more aware of the issue as optometrists, but also the population getting older. At least 1 in 5 in the UK will have dry eye now. And that's really growing by about 3% a year, partly because the population is getting older, but also environmental triggers, VDU use, pollution, etc. And the actual growth in sales of dry eye products is about 10% a year. So I think patients and people in general are realizing that there's stuff that can be done and can be used to help them. So in terms of the numbers, if you just think for a second how often you see someone with myopia. In the UK, about 12 to 18 million people are short-sighted. And interestingly, not that far off, about 11 million people have dry eye. So if you think the number of people you see every day, where you're giving them glasses for their myopia, and that is roughly the number of patients that you should be dealing with their dry eye as well. So the scope is enormous. So in terms of what we're dealing with, I really see ophthalmologists as just dealing with the tip of the iceberg, the really severe Sjogren's syndromes and the stuff that is very serious and sight-threatening, that kind of thing. And really that's where I see us coming in to mop up the enormous bit under the surface that's just the general dry eye, the meibomian gland dysfunction, and really only needing ophthalmologists to get involved just when it becomes too severe, too serious a level for us to really deal with it. So in terms of actual impact in society, we know lots of studies have been done. We know that it reduces how productive people are at work, and half of all our contact lens patients at some point will get dry eye. Patients actually with dry eye are far more likely to suffer when they're doing any sort of concentrated task, primarily because blinking goes down. We only blink about 1/3 of the amount when we're concentrating, be it reading, computing, TV. So that really does have an impact as well. And we know, obviously, when people have dry eye, that it affects vision. They come in with smearing, and it's a real under-realized problem, even amongst optometrists, that it does actually affect people's sight and clarity. So in terms of what we're actually dealing with, you're probably all aware by now of the JEWS report that came out a few years ago, followed by what we call the meibomian gland dysfunction report as well. And amongst other things, they came up with some really great definitions of what dry eye really encompasses. And you only really need to remember 3 or 4 things from those definitions. So dry eye itself, we know is a result of the tear film becoming unstable. It increases the osmolarity of the tears and causes inflammation. Okay? Meibomian gland dysfunction, in essence, occurs when the glands themselves become obstructed, so the openings of the glands get blocked. Okay? You also get changes in the quality and the quantity of the meibum that's expressed from those glands. And again, you see that word, inflammation. Both dry eye, meibomian gland dysfunction, they're all sort of inextricably linked, and they all revolve around an inflammatory disease. So when we think about the sort of vicious cycle of dry eye, you can really start to consider the various points on the circle that make up the sort of overarching idea about dry eye itself. And we know, for example, if we start at the top, that we have this tear film instability. And that really feeds into the fact that when you have an unstable tear film, you get an increase in the rate of evaporation of the tears from the surface. That increased evaporation reduces the actual volume of the tears, and when you have less tears but the same amount of salts and things, you get an increase in the osmolarity, okay? And that increase in osmolarity sets up a sort of chain where you start getting damage to the cells. So the cells are trying to balance out the osmolarity, so they will literally dehydrate in order to try and balance out the osmolarity there. So that's why you get the cell damage that you see as staining on the corneal surface. Leading on from that, you then get an inflammatory reaction, so you get lots of inflammatory markers released into the tears. And those do harm, so they harm the conjunctiva, the goblet cells that make our mucin, and the general surface of the eye and the lids as well. So those inflammatory markers are all involved in that process. And all of that then causes yet more tear film instability. So it really is this vicious cycle, okay? It also helps to think about where on that cycle all our different types of dry eye and all our different problems arise. So if you consider a contact lens wearer, if they're just otherwise fairly okay but just getting a bit of dry eye with their contact lenses, that will feed into the top. So inserting a contact lens into an eye will trigger a bit of an instability in the tear film. So that's how you're setting off that cycle in motion. If you have a patient that has meibomian gland dysfunction, then you're feeding into the bit where you increase the evaporation. If you have a dry environment, so the patient is otherwise fine, but they're a computer user or they're in air conditioning all day, suddenly you're feeding them into that system because they're getting an increased osmolarity and a drying out of the tears. If they have some other underlying issue, then if they have low tear production, aqueous production, then they're going to feed in right at the site where they get inflammation. But the interesting thing is, it doesn't actually matter where any one individual will feed into that system, because they will just end up on that never-ending loop, that circle of dry eye and inflammation. So when I'm actually performing, if you like, a dry eye consultation in my clinics, I really think of it as a story. And the beginning section of the story is gaining the history and symptoms from that patient. And I usually take half an hour with them. And of that half an hour, about a quarter of my time is talking to them, getting a feel for their problems, when it happens, when they notice it, what they've tried already, just really getting a bigger picture. Personally, I don't use questionnaires, but that's just a personal preference. I just tend to quiz them at the time. So the middle section, obviously, having a look at the patient, doing a workup on the slit lamp, and that will take me, again, about a quarter of the time. And then I think the real key, the really important bit, is actually the end, where you talk to the patient, you explain exactly what's happening, use diagrams, use pictures. If you've got anterior imaging, show them what you're seeing. That really does help to have quite a powerful impact on how the patient sees it as well. And also then, once you've got it clear in their heads what's going on, what you're going to do about it. And when I'm talking through a process of treatment and management, I always sort of show them what I want them to do a bit of demonstration with them, because compliance is infinitely better, and you won't get people starting to do lid scrubs on the inside of their lids and things instead. So the actual dry eye workup really only consists of 5 key steps, okay? So step 1, talk to the patient. Step 2, I have a really, really good look at lids. Number 3, obviously then looking at the tear film and the surface of the eye, diagnosing and explaining, and then coming up with our plans, and also not forgetting what happens next. Once you've gone home and you've started this regime, what then, what next? So, on the slit lamp, I try to approach it fairly methodically, fairly logically, mostly so I just don't forget to do things in the right order. So I always work from front to back, obviously non-invasive to invasive. If you start squeezing glands before you've measured breakup, you won't be able to measure an accurate breakup after you've ruined the tears by making them greasy. So always look first, then examine, and then start to prod and poke. I don't know how many of you enjoy squeezing. I'm a real squeezer, so that's my favorite bit, and I like to save it to the end. So this is roughly my order of events, and so basically when I said having a look, just looking generally with a white light, spotting things, looking at things you might want to look into more detail in once you've done the overall assessment. looking at redness, particularly the conjunctiva, but also the lid margins as well. Instilling fluorescein and lissamine green, I usually do that at the same time. I think whatever approach you take, as long as you're consistent, you do it every patient you see, then your results will be repeatable. So then looking at tear breakup time and lid wiper, corneal staining and the pattern of the staining as well. If it's quite a streaky, sort of vertical streaky stain on the staining and tear breakup as well, that tends to indicate more towards meibomian gland dysfunction, so evaporative issues. If it's a blinking issue, you tend to see the classic sort of staining in the palpebral aperture sort of zone, if you like. Tear prism and lip cough, which I'll hopefully show you shortly on the slit lamp. And then the lid assessment really comes last. So when I'm going to start properly looking at the blepharitis, picking off the actual crust, that's why I start to really enjoy this bit, and squeezing the glands, okay? Years ago, I just looked at a lid and looked at the glands. I really don't believe you can assess a meibomian gland without squeezing them, okay? Because there's quite a significant proportion of people that will have dysfunction that you won't be able to see. It's called non-obvious MGD, and there's no inflammation. The gland openings sort of look okay, and then you start squeezing, and all is revealed. So you really can't assess a lid and a gland without squeezing. So I really think that's key. So when we're having a look at lids, do bear in mind, we know, lots of studies show us that 80% of dry eye relates to either MGD or bleph or both. So 80% of your dry eye patients will have these problems, okay? So it's really the bulk of the work that I deal with, certainly. So when you're looking at lids, you're really only looking for these few things, okay? So looking at the glands, looking at the anterior blepharitis, if you can, trying to decide whether you think it's staph, seborrheic, or Demodex. I'll talk about that in a sec. But also not forgetting things like how well the lids close together. If there's an issue with the lids and they're not opposing properly on blinking, that's going to affect it as well. And the position of the ducts, the puncture as well. Are they sat on the tear prism? Are they able to drain the tears out the eye? So when we look at blepharitis and start to really look at the different types, seborrheic really often goes hand in hand with general dermatitis. So if a patient comes in, they've often got signs on their cheeks of sort of slightly red cheeks, maybe rosacea, but often sort of flaky skin as well. It tends to be like a greasy appearance. So when you look on the slit lamp, the crusts are really oily and greasy. And much more oily than the other two. So the greasy oily is really the thing to consider. So with staph, you get a lot more inflammation. It looks like a much angrier looking eye, okay? You tend to get more significant sequelae. So the lashes start to grow the wrong way. The collarettes, the crust that you have, when you start pulling them off, you tend to find that you get sort of little raw patches, little ulcerated patches underneath them. They just look a lot angrier. But again, it's hard to tell until you start to actually start pulling off the crusts properly in practice. You often get secondary issues with these, so things like marginal keratitis and ulceration of the edge of the cornea. And you might even see sort of these Panus type reactions where at some point in the past the patient has had a keratitis and not necessarily realized, and you get the ingrowth of the vessels in that region. So Demodex, fairly hot topic nowadays. So Demodex themselves are mites that live on all of us. By the time we're 70, the prevalence is 100%. So if you haven't got them yet, you will. And basically, it's thought to be sort of an overreaction of the immune system to what should be normal common cell bugs that we all have. It's thought to also be a potential trigger of rosacea. So if you have a patient that's known to have rosacea, then often they'll have Demodex blepharitis as their form of blepharitis. The hallmark sign for Demodex is what we call cylindrical dandruff, okay? And I'll show you that in a moment. But if you see that, you can pretty much diagnose Demodex without needing to even find the mites, okay? And it's just really pattern recognition. The more familiar you get with what they look like, the more you'll see it in everyone all the time, like I do now. And again, the other sort of strong indicator with Demodex is often those recalcitrant cases where they've tried lots and lots of treatments, they've nagging you because nothing's worked, it's not helping, they've had it for years, and often this type of blepharitis doesn't really respond that well to normal sorts of lid hygiene. So if it's that kind of patient, really, really look for Demodex, because often it's there. The treatment for that is a tea tree oil solution. So in practice, I mix up 50% tea tree with a carrier oil. Macadamia nut oil is what they use in the studies, and then apply that onto the lids using a cotton bud. And if we get time, I'll show you. But that then kills the mites that are there, and then about 3 weeks later, you want to do it again to mop up any eggs and things that hadn't hatched and kill those as well. And then it's often a case that patient's susceptible, so it's going to come back again. So I usually see them around about every 4 to 6 months once they're under control, to just keep doing it in practice and keep following up with that sort of a cleaning and a treatment for them. That's it. So I can't get the laser to shine on the TV, but the far picture obviously are the classic cylindrical dandruff, the collarettes. And if you look, you can see it's not really any inflammation. The lid's pretty quiet, but you just get these really sort of tightly knit collarettes that are right at the root of the lashes. And when you pull those off, those are the mites, okay? So those are the mite tails. This is just a 40 mag on a slit lamp, so you can see them in practice, but you've got to pull out the collarettes in order to visualize the mites. You can even pull them out and look at their heads if you want. So with meibomian gland dysfunction, obviously you get the classic signs, the sort of plugged orifices and even the sort of little bulge meibum that you sometimes see if it's keratinized. But don't forget the slightly more subtle things. Tear prism foam. If you see that, you know there's an issue with the lipids, but you also know that there's likely to be staph present. What happens is the staph kind of interfere with the lipids, and you get a frothing of the tears. You often see these kind of signs, the notching of the glands. What's happening underneath that is that the gland itself is atrophied and scarred, and the scar tissue shrinks and pulls the lid down, so you get a notch appearance above a dropped out gland, basically. So if you see those, A, you know there's MGD there, but B, you also know it's been there for some time because it's had long enough to cause that issue, okay? Obviously, you get issues with the appearance of the lipid in the tears, those funny little vessels that you see on the surface of the lids. Don't ask me to pronounce it, telangiectasic vessels. And again, once you've looked at all that, then you get in there and squeeze, okay? And I use paddles to do that. I'll show you. And basically, you're looking at two things: how easy it is to squeeze them, so the sort of expressibility, what comes out, and the quality of what you're squeezing as well. So is it toothpastey and thick, or is it nice and runny and clear? So here is also on the left there, you can actually see, bang in the center of that image, that there's gland dropout. The white that you see leading up from the bottom is actually meibomian glands, okay? It does help when you have meibography to visualize it even better with infrared, but you can see the glands to an extent just by averting a lid and looking on a slit lamp. So where you see the redder patch on that inverted lid there, that's a gland that's disappeared. They've got gland dropout, and either side where the white is, you've got active meibomian glands, okay? The image on the right there really shows a really thickened lid margin, and you can see it's quite notched down the center where you tend to get the glands appearing, and also there's those vessels, those telangiectasic vessels that appear just when it's a chronic issue. So this is a video. I'm hoping it will play. Okay, so those are the paddles that I talked about, okay? And basically what you do is you just fit them either side of the lid and squeeze. And that's how you assess, okay? So you can see, before I did that, you couldn't really see anything on the surface. The glands looked all right. You won't always get every gland expressing something. It just depends where you are on the cycle of that gland. But if you could run it again for me. But basically, what you do see, yeah, thanks. What you do see is the thickness, the quality of that stuff. So the first couple of glands that we squeeze there, I would rate at 4. You know, that's really thick and toothpastey. So we really need to get on top of clearing those glands out. I also do this therapeutically now in practice. So people that have meibomian gland dysfunction, I will do this procedure because we know that physical expression of the meibum that's stuck inside, even if they're really good at hot compressing, you kind of need to get that stuff out. You need to give them a clean slate with which to work. So I now, as a matter of routine on my MGD patients, whenever I see them, will squeeze their glands. It also allows me to work out what's going on, yeah. Do I anaesthetize them? Yes, I do. I like my patients, so yeah, I do. Brilliant. So we'll move on. So after we've done all that, treatment. These days, more so than ever, there is so much that can be done with a dry eye patient, okay? It's not just, oh, try these drops, try, you know. There truly is so much. And the best thing to do is try to approach it in a methodical, as logical as you can make it way, and do it a bit at a time, okay? So I won't go through them all because you know the list. So one of the key things I find in reality is that if you bombard that patient with loads of stuff, oh, do this for me, do that, spend 3 hours at night treating your dry eye, their compliance is terrible, and also the biggest issue you have is that you won't know which one of those plethora of things they're doing is actually working. So I always do it stepwise and do it maybe just 2, maybe 3 things if I'm really at a push, but usually 1 or 2 things each time. And you can always add to that list later if it's not, you know, doing what you want it to do. But that way, A, you've got extra things you can do with them later on, but B, it's particularly the compliance issues with a patient at first. So how I do it in practice, I always start, so when I've seen my patient, usually after an eye exam, I'll tell them that, you know, they've got dry eye, particularly if they're symptomatic as well. I don't tend to tag it onto the end of an eye exam. I did it years ago. I found that I could never get the information over in the time I had, and the compliance was more difficult. So I always have separate clinic appointments. So if you're lucky enough and able to do that, it works infinitely better doing it that way. So I give them a leaflet that tells them all about the service and what I charge, and then they can go away and decide and have a think about it. So once we've done the assessment and decided what plan we're going to follow, I will always let them know their options, okay? So I won't say, you have to use this, you have to use that, but I'll often guide them, you know, through what I think is best. I will always write a management plan, and usually I email it to the patient. So just have a pro forma and add and subtract from it as required. And then they've got something to refer back to. Do not underestimate how little the patient will remember when they walk out the door. I think the stats are like 10% or something, so do make sure you've written it down because they will forget. Also, letting them know that they can contact me back, so either through my team or emailing me if they do have any significant questions. And always, always follow the patient up. As a matter of routine, I see my long-standing dry eye cases every 6 months. If they're new to me, I usually review them after 3 because that's how long it takes for the treatments to start to kick in. I don't do it much sooner than that because you won't know whether it's actually working. So you need to allow it at least 3 months to really get going and warn the patient of that as well. Otherwise, they'll ring you in a week and say, my eyes aren't any better. So always tell them that it's going to be a long-term management strategy.